Welcome to the Radiographics Podcast. I'm Ross Frederick. This week on the podcast, I will be discussing diseases involving the greater wing of the sphenoid bone, and Dr. Gibbs will be talking about the pearls and pitfalls of soft tissue and bone biopsies. Anatomy and diseases of the greater wings of the sphenoid bone. The sphenoid bone comprises a central body, greater wings, lesser wings, and pterygoid processes. We will be specifically focusing on the greater wings, which project laterally from the central body and form the anterior and medial portions of the floor of the middle cranial fossa. There are many skull-base foramina in the greater wing, which transmit important neurovascular structures. As an osseous structure, the greater wing can be affected by numerous benign and malignant primary or secondary bone lesions. Several non-osseous diseases can also affect the greater wing, either through direct involvement or through contiguous extension, such as from perineural spread from a head and neck cancer. The complex three-dimensional wing shape of the greater wing and the wide array of pathologies that affect this bone can make it challenging for the radiologist to report the imaging findings accurately, especially in relation to the important skull-base foramina. For accurate reporting of abnormalities affecting the greater wing, an understanding of the anatomy of the greater wing is indispensable. The central portion of the skull base, which is posterior to the frontal and ethmoid bones and anterior to the occipital and temporal bones, is formed by the sphenoid bone. The sphenoid bone mainly comprises a central body and a pair of large lateral triangular wings that are arranged in a way that resembles the shape of a butterfly. It also has two smaller anterolateral wings called the lesser wings and two antero-inferior pterygoid processes. The greater wings are lateral projections from the sphenoid body that make up most of the posterior wall of the orbits and the anterior and medial aspects of the floor of the middle cranial fossa. The greater wings contain numerous foramina. The cleft between the lesser and greater wings is the superior orbital fissure, which transmits the cranial nerves 3, 4, V1, and 6, and the superior ophthalmic vein. The foramen rotundum transmits cranial nerve V2 from the cavernous sinus to the pterygopalatine fossa. The foramen ovale is a relatively wide posteromedial opening of the greater wing that serves as a communication between the middle cranial fossa and the infratemporal fossa, which allows passage of V3 and the accessory meningeal artery. Posterolateral to the foramen ovale is the foramen spinosum, through which the meningeal branch of the mandibular nerve and the middle meningeal artery and vein traverse. The benign and malignant lesions affecting the greater wing can be intrinsic or extrinsic in origin, but first let's cover an important normal variant, arrested pneumatization of the sphenoid sinus. During normal development, there is progressive replacement of the red bone marrow with adipose tissue. Bones that go through the process of pneumatization show fat substitution at an earlier stage of development than bones in which pneumatization does not occur. Thus, if the process is not completed, bone will contain yellow marrow into adulthood and referred to as arrested pneumatization. Typically found in the sphenoid bone as an incidental radiologic finding, it is not a true lesion, but in fact a benign developmental variation. The four criteria for this diagnosis are location and a place of normal pneumatization, fatty content, no mass effect, and normal appearance of the associated skull-base foramina. On CT, the area should have sclerotic and well-circumscribed margins and internal curvilinear calcifications. They do not enhance. Now let's discuss intrinsic benign lesions of the greater wing. Skull base and facial bones are commonly affected by fibrous dysplasia and are the second most common site of involvement in the body, accounting for about 1/4 of cases. Fibrous dysplasia is a congenital condition. On CT, fibrous dysplasia typically appears as an expanded medullary bone with ground glass opacity, causing endosseal scalloping and cortical thinning. Depending on the proportion of the osseous and fibrous components and the presence or absence of hemorrhage and/or cystic degeneration, there are 3 different patterns of fibrous dysplasia that have been described: homogeneously sclerotic, which typically shows the diffuse ground glass opacity, lytic, and mixed fibrous dysplasia. Although classic low signal intensity from the osseous components is seen on MRI, this is not always present and the appearance is commonly confusing, especially on MRI, with heterogeneous and avid enhancement from the fibrous component masquerading as a tumor. Correlation with CT images is always useful when the MRI appearance is confusing or inconclusive. Intraosseous venous malformation is a non-tumorous, slow-growing vascular anomaly that can involve any skull bone, including the greater wing. It is composed of angiomatous channels between thickened osseous trabeculae, resulting in the characteristic sunburst or honeycomb pattern on CT. T2-weighted MRI shows the typical bunch of grapes appearance from the hypointense trabeculae and the hyperintense vascular channels, which are also responsible for progressive enhancement. Meningiomas are the most common primary intracranial tumors and occur predominantly in women, with an increasing incidence with age. Most meningiomas are benign and typical, WHO grade 1. Intratumoral cystic changes, edema and/or enhancement in the adjacent brain parenchyma, and the presence of a draining vein are predictive findings of atypical meningiomas, which are WOH grades 2 and 3. Approximately half of meningiomas are located at the skull base, and the greater wing is one of the most common sites affected. The portion of the greater wing that forms the posterolateral orbital wall is commonly involved, and these meningiomas are more aptly known as sphenoorbital meningiomas. Sphenoorbital meningiomas can be primarily intraosseous or can originate from the adjacent meninges. CT is the best imaging tool for characterizing the typical osseous changes of sphenoorbital meningiomas and helping to discern them from other hyperostotic conditions, mainly fibrous dysplasia. Although more than one pattern of hyperostosis may be found in this subgroup of meningiomas, the periosteal pattern is the most typical and useful because it is not expected in fibrous dysplasia, which does not induce periosteal new bone formation. Surface irregularity of the hyperostotic bone is also characteristic of meningiomas. Both intraorbital and intracranial soft tissue components of sphenoorbital meningiomas are best evaluated with MRI. Typically, meningiomas are isointense to gray matter on T1 and T2 weighted images, showing intense, often homogeneous, contrast enhancement. An enhancing dural tail is also a classic feature of meningiomas. The lesions may spread to the frontotemporal vault, the cavernous sinus, or the orbits. Cavernous sinus extension may simply involve the lateral wall, variably affecting cranial nerves 3, 4, V1, and V2, or may also invade the cavernous sinus itself, with variable encasement of the internal carotid artery. There may be invasion of the optic canal and the superior orbital fissure, with involvement of the structures traversing through it. Direct extension along the posterolateral orbital wall may involve the extraconal orbit or the extraocular muscles. The intracranial component usually causes mass effect on the adjacent brain parenchyma. Higher grade tumors may involve the brain parenchyma, in which altered signal intensity and enhancement may be seen. Extracranial extension is also possible, in which a soft tissue mass involves the masticator space. Excision of meningiomas, as well as any other tumor involving the medial compartment of the cavernous sinus, cannot be achieved without causing morbidity. So, during the preoperative MRI eval, it is crucial to determine whether the tumor is restricted to the lateral compartment of the cavernous sinus, and to identify its relationship with the cavernous internal carotid artery. It is critical to determine whether the tumor involves the anterior clinoid process. In these cases, an anterior clinoidectomy is required. Residual tumor in the medial compartment should be managed with observation or radiation therapy, depending on cellular atypia, the proliferative index, patient age, and clinical condition. The tumor portion that infiltrates the superior orbital fissure can be followed and treated with radiation therapy. Langerhans cell histiocytosis is a rare disorder with peak incidence in patients aged 1 to 3 years that is characterized by monoclonal growth of bone marrow-derived Langerhans cells. Bone lesions are either solitary or multiple and lead to osseous expansion and eventually cause a cortical breach. Lesions affecting the greater wing demonstrate a non-sclerotic punched-out appearance on CT. On MRI, they are T1 hypointense when compared with gray matter and T2 hyperintense and exhibit avid enhancement. The soft tissue component of the tumor grows toward the middle cranial fossa and the orbital cavity. These lesions can also have dural tails. Now let's discuss extrinsic benign lesions of the greater wing. The term cephalocele is used generically to describe herniation of intracranial contents through a defect in the skull base or calvarial bones. The herniated material could be meninges and CSF, called a meningocele, brain parenchyma, called an encephalocele, or a combination of both, called a meningoencephalocele. CT shows the bone defect, and MRI shows the content of the herniation. Aberrant arachnoid granulations can also be seen along the greater wing, especially among patients with elevated intracranial pressure. Schwannomas are benign tumors that arise from the sheath of any of the multiple nerves that pass through the foramina in or adjacent to the greater wing, and they usually have typical benign imaging features such as well-defined margins, displacement of adjacent structures, and osseous remodeling. Among the cranial nerves involved by schwannomas, the vestibulocochlear nerve accounts for the majority, followed by the trigeminal nerve. When they arise from V2 or V3, there can be enlargement of the foramen rotundum and foramen ovale. Enlarged bone foramina can be seen with CT. However, most tumors are detected with T2-weighted MRI, where lesions show characteristic findings of high signal intensity and moderate to intense enhancement. Lesions can be partially cystic, especially if they are large. Intratumoral microhemorrhage, which is seen as areas of low signal intensity on T2-weighted images, may be present and is better shown on susceptibility-weighted images. Sphenoid dysplasia can be isolated or can be due to extension of a plexiform neurofibroma in the setting of NF1 to the vicinity of the bone, which induces osseous changes that progress over time. In addition to deformity and hypoplasia of the greater wing, anterior displacement of the greater wing and elevation of the lesser wing can occur, thus causing enlargement of the middle cranial fossa, proptosis, and widening of the superior orbital fissure. Juvenile angiofibroma is a locally aggressive, although benign, vascular neoplasm originating at or near the sphenopalatine foramen. The typical patient who presents clinically with juvenile angiofibroma is a teenage boy with a nasal obstruction and epistaxis, and the imaging appearance of a hypervascularized mass centered at the sphenopalatine foramen. As in many diseases of the skull base, CT is helpful for demonstrating bone changes, whereas MRI is used to better differentiate the tumor from sinonasal secretions and to evaluate intracranial extension and bone marrow invasion. MRI shows an avidly enhancing, richly vascular mass with multiple flow voids. Although different growth patterns are described, juvenile angiofibroma frequently spreads anterolaterally through the pterygopalatine fossa, filling it and causing bowing of the posterior wall of the maxillary sinus. As it continues to grow, the tumor may reach the infratemporal fossa and the inferior orbital fissure, may erode the sphenoid bone, and may even invade the middle cranial fossa. Infections that reach the greater wing are usually advanced and life-threatening. Osteomyelitis of the skull base is an important clinical entity, not only because of its local aggressiveness, but also because the diagnosis is often delayed, and most patients with it are immunocompromised. The process is usually secondary to bacterial otitis externa. The infection can reach the adjacent suprahyoid neck spaces and then may affect various cranial nerves and may spread along the skull base foramina. It can also spread to the floor of the middle cranial fossa and result in cavernous sinus thrombosis. There are also intrinsic malignant lesions that can affect the greater wing, such as sarcomas, hematologic malignancies, and metastases. Let's discuss extrinsic malignant lesions of the greater wing. Contiguous involvement of malignancies arising in the suprahyoid neck and facial structures account for most of the aggressive lesions affecting the skull base, including the greater wing. They can result from direct extension, perineural spread through the greater wing foramina, or both. In children, parameningeal rhabdomyosarcomas from the nasopharynx, parapharyngeal space, masticator space, or paranasal sinuses may affect the greater wing directly because of the proximity to the skull base, and may spread along V2 and V3 in the foramen rotundum and foramen ovale. Orbital rhabdomyosarcomas can invade the orbital fissures and the greater wing. Because they occur frequently, cutaneous and mucosal squamous cell carcinomas account for most cases of perineural spread among head and neck malignancies. However, adenoid cystic carcinoma from the salivary glands is the cancer type that is most likely to develop this complication. Nasopharyngeal carcinomas may reach the sphenopalatine foramen, gaining access to the pterygopalatine fossa, and then extend along V2. When these tumors invade the masticator space, perineural spread along V2 is of concern. Malignancies can also involve V3 through its cutaneous branches or through the auriculotemporal nerve that runs in the parotid gland and in the stylomandibular tunnel. It is useful to have a mental checklist of the vital structures near the greater wing. Involvement of the nerves in the lateral wall of the cavernous sinus and encasement of the cavernous internal carotid artery are features that can alter the surgical approach or affect planning for radiation therapy. Also, involvement of the skull base foramina can lead to antegrade or retrograde spread of the tumors and has the potential to change patient care. Such features also help in determining the prognosis for patients with these lesions. Similarly, extension into the orbit, optic canal, and superior orbital fissure is essential to be evaluated if orbital salvage is being considered at surgery. The presence and extent of involvement of the temporal fossa could determine and guide the surgical approach for optimal cosmesis in qualifying cases. Aggressive lesions may involve the subjacent brain parenchyma, and is essential for radiologists to search for and report on abnormal signal intensity and/or enhancement in the brain. Given the three-dimensional curved shape of the greater wing, the size of a lesion can be difficult to measure accurately. Lesions, therefore, should be measured in all three planes as best as possible. Now, let's hear from Dr. Gibbs about soft tissue and bone marrow biopsies.
Pearls and pitfalls for soft tissue and bone biopsies, a cross-institutional review. I liked this article because it provides very practical information that all radiology residents need to know, and many practicing radiologists still perform biopsies as well. But also, the approach to musculoskeletal lesions is a bit different than those I was taught and used from the neuro side for spine. Image-guided percutaneous biopsy has largely replaced surgical biopsy as the preferred method for establishing a histologic diagnosis in a soft tissue or bone tumor. These biopsies are minimally invasive with low complication rates and have a high level of diagnostic accuracy. Given the increasing number of percutaneous biopsies performed for soft tissue and bone tumors, radiologists must not only know how to perform the procedure safely with technical accuracy, but also have a fundamental understanding of key considerations before, during, and after the procedure. The first and most critical task is to decide whether to even do the biopsy. If a biopsy is indicated, the biopsy planning phase should include consultation with the referring orthopedic oncologist, selection of the most appropriate imaging modality for guidance, identification of the highest yield part of the lesion to target, evaluation of site-specific anatomic considerations for the biopsy tract, and management of anticoagulant medications. Once planning is complete, peri-procedural considerations include the use of local anesthetics and moderate sedation, technical factors, modality-specific procedural considerations, and specimen handling. Finally, post-procedural considerations include management of non-diagnostic biopsy results and evaluating imaging features of tumor recurrence. Okay, let's go into a little more depth. Pre-procedural considerations. Often, solitary bone and soft tissue lesions show nonspecific imaging findings that do not allow definitive characterization as benign or malignant. Unless a lesion exhibits characteristics that are unambiguously benign, an image-guided biopsy is often warranted. If the biopsy request is appropriate, imaging review should focus on determining the ideal biopsy site and the best approach to obtain a specimen safely. If available imaging is inadequate, further imaging should definitely be performed before proceeding with the biopsy. Let's start with some of the pearls that the authors have shared with us. Stress versus pathologic fracture. Although stress and pathologic fractures may appear radiographically similar, differentiating the two entities is important given the vastly different treatment implications. Histopathologic differentiation is also challenging because the immature osteoid of a stress fracture may appear similar to bone-forming tumors, including osteosarcoma. Conversely, the misdiagnosis of a pathologic fracture can result in delayed diagnosis of a neoplasm. On radiographs, a stress fracture may show aggressive features, including extensive osteolytic change or an irregular periostitis that can overlap with features of an osteolytic or bone-forming tumor. Clinical history is often helpful in discerning between the two entities. Pathologic fractures are more frequently encountered in the elderly, with minimal to no antecedent trauma, or in patients with known metastatic disease. Stress fractures typically occur in young, otherwise healthy patients who are engaged in repetitive activities. Most pathologic fractures occur in the subtrochanteric femur, humeral neck, or vertebral bodies, while the location of a stress fracture is specific to the activity which caused it. An avulsion fracture at the lesser trochanter in an adult is considered pathognomonic for a pathologic fracture. When the clinical picture and radiographic findings remain equivocal for stress versus pathologic fracture, MRI is the preferred imaging modality for further evaluation. T1 weighted images are the most helpful, with special attention to both the homogeneity and margins of the signal intensity abnormality around the fracture plane. In pathologic fractures, the adjacent abnormality in T1 weighted marrow signal is primarily due to the underlying lesion, and therefore has a geographic appearance with convex margins and diffuse hypointensity. In contrast, T1 hypointensity adjacent to a stress fracture is secondary to hemorrhage and edema, which appear indistinct and patchy, with interposed fatty marrow that gradually blends with the normal bone marrow. An additional MRI feature that may be useful in distinguishing stress from pathologic fractures is a clearly demarcated fracture plane extending from the cortex into the central medullary cavity, which is most typical of stress fractures. Given the infiltrative nature of bone tumors, a pathologic fracture plane is often completely obscured or indistinct. And of course, pathologic fracture is the favored diagnosis in patients with an enhancing soft tissue mass, necrotic subjacent soft tissues, endosteal scalloping, aggressive periostitis, or cortical erosions. How about tumor versus infection? There may be substantial overlap in the imaging appearance of infectious and neoplastic processes, and the radiologist may be the first physician to consider infection as a diagnostic alternative to tumor. If an infectious process is a diagnostic consideration, the biopsy samples must be sent for both microbiologic and histologic analysis to maximize diagnostic yield and avoid repeat biopsy. Although a biopsy may be warranted for either indication, several imaging findings, if present, may help distinguish these causes. This is a new one I hadn't heard of, the penumbra sign. This is helpful in distinguishing subacute osteomyelitis and soft tissue abscess from neoplasm. The penumbra sign corresponds to a thin layer of granulation tissue that lines the cavities of both bone and soft tissue abscesses. This thin layer is relatively hyperintense on T1 when compared with the content of the central abscess or the surrounding bone marrow and soft tissue edema. This granulation tissue is vascularized and avidly enhances. How about hematoma versus hemorrhagic neoplasm? Distinguishing a bland hematoma from a hemorrhagic sarcoma can be challenging. Formation of an intramuscular bland hematoma is unusual in a patient without an underlying coagulopathy or a history of trauma. In addition, bland hematomas usually grow rapidly within hours and are painful. Soft tissue sarcomas usually manifest spontaneously with slow growth and are often relatively painless in the early stages. These distinguishing features reiterate the importance of reviewing the patient's clinical history. The size of the hematoma should be proportional to the severity of the trauma. For instance, a large hematoma in a patient who experienced low-velocity trauma is atypical and should raise suspicion of a hemorrhagic sarcoma, unless the patient has an underlying coagulopathy. When a diagnostic dilemma exists, contrast-enhanced MR is the preferred imaging modality to distinguish them. The appearance of a bland hematoma varies on MR depending on the age of the collection. Acute hematoma in a patient with muscle strain may have a feathery appearance along the muscle fibers, surrounding edema, and T1 shortening that persists on fat-saturated sequences, representing methemoglobin. Okay, let's move to biopsy planning. The importance of thorough pre-biopsy planning in the workup of a musculoskeletal lesion cannot be overstated. Planning a percutaneous biopsy often requires more time and effort than performing the actual procedure. The decisions regarding the selection of the modality, the type of needle, the biopsy path, the specific target in a lesion, and the expected pathologic findings should be made well before the patient arrives in the department. Failure to plan appropriately can result in non-diagnostic specimens, delays in initiating treatment, complications in definitive treatment, and unnecessary injury to the patient. Although open surgical biopsy remains the gold standard, core needle biopsy is the preferred technique for sampling musculoskeletal lesions. This can be performed in an outpatient setting at a lower cost than that of an open biopsy, and the patients prefer it too. Any indeterminate solitary lesion should be considered a primary tumor until proven otherwise. Close consultation with the referring orthopedic oncologic surgeon who will perform the definitive tumor resection is necessary in biopsy planning. Although the actual incidence of biopsy tract tumor seeding from a percutaneous biopsy remains a controversial topic, failure to coordinate the biopsy path with a definitive surgical treatment could complicate surgical resection and sacrifice limb-sparing options. In general, use the shortest route that violates the fewest anatomic compartments. In addition, care should be taken to avoid traversing soft tissue structures needed for planned flap or soft tissue reconstruction. Limb-sparing surgery is a preferred outcome in patients with musculoskeletal malignancy. A poorly planned biopsy that unnecessarily traverses the neurovascular structures or crosses multiple anatomic compartments could eliminate limb-sparing surgical options or necessitate increased chemotherapy or radiation. What are the factors that affect biopsy yield? The goal of any biopsy is to provide adequate samples for the pathologist to arrive at a definitive histopathologic diagnosis. Diagnostic yield, defined as the percentage of biopsies resulting in a diagnosis, can be influenced by operator technical factors and lesion-specific characteristics. The diagnostic yield for all core biopsies is 70 to 98%. Operator technical factors that affect biopsy yield include the number of specimens, specimen size, and needle gauge. Yield is maximized when a minimum of 3 core biopsy specimens are obtained, or 4 specimens if you're doing soft tissue lesions. The yield also increases with specimen length. The needle gauge has been shown to have little effect on tissue diagnosis when at least an 18-gauge needle is used. Targeting the most aggressive portion of a heterogeneous lesion is critical to ensure proper staging and treatment. Aggressive tumors often have necrotic or hemorrhagic components that do not contain viable tissue. Erroneously sampling intralesional necrotic tissue or a secondary aneurysmal bone cyst results in delayed diagnosis and puts the patient through the inherent risks of a second invasive diagnostic procedure. This pitfall is avoided by targeting the solid-enhancing, destructive, or most aggressive portion of the lesion. Interpreting biopsy results. Biopsy results are considered non-diagnostic when the pathologist is unable to arrive at a specific histologic diagnosis. Non-diagnostic biopsy results may still provide valuable information, or a repeat image-guided biopsy may be indicated. Image-guided biopsies that yield non-diagnostic results have been reported to occur at rates varying from 5 to 31% of cases. However, not all non-diagnostic biopsy results are equal. The utility of non-diagnostic results varies on a case-by-case basis and is dependent on lesion imaging features, clinical picture, and pre-test likelihood of malignancy. Non-diagnostic biopsy results can be reassuring when the suspicion for malignancy is low. Multiple studies have found that benign lesions have significantly higher rates of non-diagnostic biopsy results than do malignant lesions. One study in adult patients found that 67% of non-diagnostic biopsy results ultimately yielded benign diagnoses. A similar study in pediatric patients who underwent CT-guided biopsy for unclear bone lesions reported a non-diagnostic rate of 33%, and of those lesions, none ultimately proved to be malignant. In a retrospective review evaluating the clinical usefulness of non-diagnostic biopsy results, orthopedic oncologists categorized up to 60% of non-diagnostic biopsy results as useful in guiding treatment planning. So when do you consider repeat biopsy? Repeat image-guided biopsy is likely underused by referring physicians. In a retrospective review evaluating the role of rebiopsy, nearly 40% of repeat biopsies resulted in a definitive pathologic diagnosis. However, repeat biopsies were only requested for 9% of patients in this study. Other studies have corroborated the low rates of repeat image-guided biopsy, ranging from 3 to 25%. Repeat biopsy may be warranted for cases in which the clinical and/or radiologic suspicion for malignancy is high. For malignant tumors, higher grades, metastases, and lytic components are associated with increased diagnostic yield. Lesions that are sclerotic, small, or primarily necrotic are generally of lower diagnostic yield. Of the malignancies, Ewing sarcoma and lymphoma most often yield non-diagnostic results at image-guided biopsy. If the suspicion for malignancy remains high, lesions with features associated with non-diagnostic biopsy results or lesions suspicious for Ewing sarcoma or lymphoma may be more appropriately referred for open biopsy. If the decision is made to pursue a repeat biopsy, variations in technique and an increased number of needle passes may increase diagnostic yield. The previous biopsy images should be reviewed, and if possible, an attempt should be made to sample a different portion of the lesion. So in conclusion, when it's performed properly, percutaneous image-guided musculoskeletal biopsy of both bone and soft tissue tumors is a safe and highly accurate means of establishing a definitive histologic diagnosis. The key to any successful procedure is thorough planning and should be performed in concert with the referring orthopedic oncologist to ensure the preservation of limb-sparing surgical options. The optimization of technical factors, combined with targeting the most high-yield intralesional components of the tumor, increases the probability of a diagnostic biopsy. If biopsy results are non-diagnostic, it's important to revisit the pretest likelihood of malignancy, clinical history, and imaging findings when deciding on the most appropriate course of action, including close clinical and radiologic follow-up, repeat image-guided biopsy, or open surgical biopsy.
All right, that's it for this week's podcast. Check out these articles in the newest issue, online or in print. And we will post related cases, so look for us on Twitter. We'll be back in 2 weeks for more summaries.